Next, a 36-year-old man with the end-stage kidney disease, all right, so has anemia. Which of the following is the most appropriate therapy? We all know what is the role of, you can say, kidney in the blood production. It is going to produce something known as erythropoietin via the peritubular capillary cells, right? So they are going to be producing the erythropoietin. Erythropoietin is going to stimulate the RBC production, which will not be able to possible in the end stage renal disease, and that's why we have to give the erythropoietin injection, right? It is not related to iron or folic acid or vitamin B12. This anemia is because of the lack of erythropoietin, which is not able to stimulate my bone marrow to produce the RBCs. All right. So please remember the answer over here is option A. Chalo. Let's move on to the next question. A 25-year-old medical student undergoes EEG recording. Initially, he asked to remain alert with his eyes open, followed by where he closes his eyes, TKG, high frequency, low amplitude waves, lower frequency wave originating. The frequency have been lower down, means it is not a beta wave for sure, right? Which EEG waves pattern is most likely observed when his eyes are closed, but he remains awake? So please remember the mnemonic over here is bat dance. So what is bat dance? A bat means chamgadar, right? So he dances in the night. B means beta, A means alpha, T means theta, dance ka D we are going to take. As you go from delta towards the beta, the frequency increases, right? And the frequency depends upon how much aware and awake you are, right? So if the person is awake and doing some concentration work, or let's say his eyes are open, so he is going to have the beta wave now that you are having right now. But as soon as you close your eyes and if you're going in the meditation position, you are awake but eyes closed, right? As soon as I asked eyes closed but awake, that means the person is conscious but the eyes are closed. Then he is going to have a lesser brain activity as compared to beta. He's going to have lesser frequency wave. He's going to have alpha waves, right? The person is in the light sleep. He's going to have theta waves. And if he's into the deep sleep, D for deep sleep, D for delta. Please remember, in the deep sleep, the person is going to have a delta wave. And one more thing, REM sleep, what is going to happen? The memory is formed. The NREM and REM sleep. In the NREM, mostly you're going to have the theta delta waves. But in the REM sleep, what you're going to have? You are going to have beta waves also. So REM में memory, remember, REM. REM से याद रखना, REM for remembered. The dreams are remembered. The fearful dreams are called as nightmares, right? And they are remembered. Why? Because the memory is forming in that particular time when you are in the REM sleep. And in that memory is forming, so the brain is active, and that's why you're going to have beta wave. Even the person is in the sleep right now, he's having the highest brain activity, that is beta wave. And this is a contrast situation, isn't it? We assume that the person is in the sleep, so we will get theta or delta wave, but we are getting the beta wave. So this is a paradox. So that's why the REM sleep is known as paradoxical sleep. That is not asked over here, but they have asked about the eyes closed, person awake, that is a meditation condition, alpha wave. Okay, let's move on further. All right, so accurately describes the neurological phenomena. All right, appropriate muscle tension. Tension is going to be sensed by tendon, right? So involves the sensory and motor neurons. All right, muscle contraction modulating motor neuronal activity based on Golgi tendon organ. Golgi tendon organ is going to be responsible for the reverse stretch reflex or inverse stretch reflex. It is going to be responsible for inverse stretch reflex, isn't it? So inverse stretch reflex. What is inverse stretch reflex? Whenever, let's write it over here. What is inverse stretch reflex? Whenever you have highest tension, excessive stretch causes highest tension. So you want to decrease the tension. Decrease the tension means you want to relax the muscle. Right? So whenever you are going to have a higher tension, the Golgi tendon organ will be stimulated. Why? Because there is a highest tension, which will stimulate the GTO, and this GTO will carry forward the, you can say, signals via the afferent nerve 1B. This 1B is going to go and activate something known as inhibitory interneuron. As the name suggested, it is inhibitory interneuron. So it goes and inhibit the alpha motor neuron. This alpha motor neuron is going to get inhibited. Alpha motor neuron is responsible for voluntary contraction of the muscle. Since I'm inhibiting the alpha motor neuron, the muscle will be relaxed, right? And that's why the tension of the muscle is going to get decreased. Golgi tendon organ, muscle tension is going to be decreased. Is it going to be 1A afferent nerve fiber? Yeah, no, it is 1B, not 1A. Is it monosynaptic? No, it is disynaptic. One synapse is going to be here, another synapse is going to be here. One synapse is between the Golgi tendon, the 1B afferent neuron and inhibitory interneuron. From the inhibitory interneuron to alpha motor neuron. So communication between two neurons is known as synapse. So there are two synapses. It's not monosynaptic, it is disynaptic. So this is also not true. Is it disynaptic reflex with single interneuron? Yes, that is true. Between the afferent and efferent. Efferent limb is alpha motor neuron. Afferent limb is 1B, right? Between them, we have inhibitory interneuron. That is also true, right? So uses type 2. Type 2 and 1A, both are used in the muscle spindle. That is nothing but the stretch reflex, not the inverse stretch reflex. So please remember the answer over here is option C. Option C. Okay. Again, this was a PYQ. Let's move on to the next question. Importance of muscle spindle. Now they're asking about muscle spindle. Proprioception and reflex regulation. Which of the following nerve fibers are primarily responsible for motor supply to the intrafusal muscle fiber? What about intrafusal muscle fiber? So suppose this is the muscle. In the muscle, you have the capsule, a spindle-shaped capsule. And since this spindle is present inside the muscle, we call it as muscle spindle. Inside the muscle spindle, you are going to have certain fibers, muscle fiber. We call it as intrafusal muscle fiber. Outside the muscle spindle, you have some fibers. You call it as extrafusal muscle fiber. There are going to be two types of neurons which are going to supply. One is going to supply the intrafusal muscle fiber. One is going to supply the extrafusal muscle fiber. The one which is going to supply the extrafusal muscle fiber is dominating one because extrafusal fibers are going to have more actin-myosin transbridges. So please remember, dominating one is going to be alpha. Usually you talk about alpha male, alpha female, no? So like that. So alpha, remember that alpha MN, that is motor neuron, is going to supply the extrafusal muscle fiber. On the other hand, the gamma motor neuron, which is important for the tone, that is going to supply my the intrafusal muscle fiber. And when, if you remember the Erlanger-Gassett classification, we do have only three fiber: A fiber, B fiber, C fiber. So from where this alpha gamma has come, the A fiber is further divided into four subtypes: alpha, A beta, A gamma, A delta. That A gamma is nothing but the gamma motor neuron. So I'm going to mark it as option D. Option D. All right. Yes, A is alpha and A gamma. Motor are A alpha, gamma. Proprioception, if they would have asked, I would have gone for the A alpha, but they have specifically asked for the intrafusal muscle fiber. So I'm going to mark it as A gamma. Let's move on. Maximum area in the homunculus signifies which one of the following? What is homunculus? Remember, in the cortex, you have the upside down, you can say upside down distorted map of the body. It depends on how much that particular part you use. And for the fine skill, let's say you're doing a lot of writing nowadays. So this is your skill, right? Or you're driving or you're painting. What is going to happen? Your hand will be given more area to process because your brain thinks that you're doing it again and again. That means this work is important, right? On the other hand, via the hip and trunk, you don't do much of the things. You're going to just use it for the posture and balance, right? So that area, though it is a bigger area, the back area, the hip area is bigger, but still, the muscles are also bigger, but they have given lesser processing area in the brain. All right. So, is it dependent on the size? Yeah. No, it is not going to be more muscle fibers. No, it is not dependent on the muscle fiber. Remember, even the thigh, even the back muscles, even the you can say hip muscles, they are larger muscles as compared to the distal muscles of my hand. But the fingertips will be given much more area as compared to the postural muscle. So that is not given on that. Low control and skilled movement. No, low control nahi. We require higher control. That's why we have given more processing areas, right? So maximum area is given to the one which is which requires maximum control. Okay, so that is for the preciseness of the movement. Yes, we require a precision. Even if I'm writing such a small writing, right? So homunculus, let's say homunculus. If I'm writing homunculus, so in that, I have to change the stroke of writing. So please remember, for that I require highest precision to change the, you can say, stroke of my writing, and that's why I have to give more area for that to process. So please remember that this is dependent on the preciseness or the uses of the body, right? Body part. So fingertips and lips, they have given the maximum surface area. Next. All right. So 32-year-old female, chronic pain. All right. Pain management. Modulate neurotransmitter. Fine. Considering the interaction between neurotransmitter involved in the pain modulation, what will be the effect of serotonin on the secretion on enkephalin? Please remember, it increases the enkephalin secretion, right? So there is no effect, no effect. So why they would have asked? Negligible effect bhi nahi. There is a significant effect. Please remember, the serotonin will be released from the raphe nucleus, and this raphe nucleus has a major effect on the enkephalin neurons. They are going to stimulate it. They are going to increase the enkephalin into the neurons. So see over here, this raphe nucleus. The raphe nucleus is the one which is going to release serotonin. These serotonergic, and that's why whatever neurons are coming from this raphe nucleus, they are called as serotonergic neurons. Why serotonergic neurons? Because they're releasing the serotonin. They're going to activate. These neurons are going to fall onto this red color neurons. You can see the enkephalin neurons over here. So they are going to activate these encephalinergic neurons. Please remember, these neurons act as an inhibitory interneuron. Why are releasing the enkephalin? They are going to release the pain. They will stop the pathway of the pain or action potential of the pain. But we are not bothered about what is the effect of enkephalin on the pain pathway. We are bothered about what is the serotonergic neuron doing to the enkephalin. So please remember, it is going to increase the secretion of enkephalin. It is going to increase the secretion of enkephalin. Option A. Option A. Chalo, let's move on to the next thing, that is appetite. Increased appetite and weight gain in female to have the elevated agouti related peptide levels in the hypothalamus. Which of the following best explains the physiological effect of AgRP activity? AgRP is the hunger hormone. Hunger hormones. What are the hunger hormones? We have remembered by mango in that A. Mango, M was MCH, right? A was AgRP, and neuropeptide by ghrelin and orexin, right? What were the satiety hormones? Satiety hormones was alpha MSH, right? Then you have leptin, then you have CCK-PZ, and all the intestinal hormones, right? So now let's see what is the effect of AgRP. Increase leptin sensitivity. Why the AgRP will increase the leptin sensitivity? AgRP is hunger hormone. Leptin is satiety hormone. Completely opposite. No, there is, you can say, no correlation, or they don't have synergistic effects. So this is not true. Decrease food intake via stimulation of anorexigenic pathway. No, orexia means hunger. Anorexia means lack of hunger. So this is not going to activate the anorexigenic pathways. Rather, it will activate the orexigenic pathways. That means hunger hormones. So it will activate the hunger. So this is also not true. Inhibition of melanocortin receptor leading to increased appetite. See, the melanocortin receptors, which is usually are present on this area, that is POMC, pre-opiomelanocortin. Pre-opiomelanocortin is going to release alpha MSH. So yes, the AgRP is going to inhibit my alpha MSH, Usually the satiety hormones, they're going to inhibit the hunger areas. Hunger hormones, they're going to inhibit the satiety areas so that they can do their own job, right? So they do have this correlation. So please remember, yes, it is going to inhibit these receptor, inhibition of melanocortin receptor, which is going to release the alpha MSH, which will not be able to cause the satiety. And that's why the patient will feel hungry all the time, right? And that's why the patient is going to have this, you can say, weight gain. Activation of satiety center, kya? No, it is a hunger hormone. Hunger center will be stimulated. What is the hunger center? Can you name it? It is nothing but the lateral hypothalamus, which is the thirst center also, right? Next. All right. So, which of the following mechanoreceptor is most likely responsible for detecting the skin stretch and contributing joint movement? All right. So, skin stretching and a lot of joint position changes are going on. So, what they have asked is skin stretch and joint movement is done by what is that? Pacinian kya? Pacinian is important for the pressure and high frequency vibration, has nothing to do with the joint movement and skin stretch. Meisner's capsule, please remember, slow vibration. It is for the slow vibration, touch, and two-point discrimination. But it is not for the skin stretch or joint movement. It is present superficially. Now, for joint, in the joint capsule, we should have the little bit deeper, you can say, receptor. Ruffini corpuscle, on the other hand, yes, Ruffini corpuscle, they are going to be helping me in the joint movement and skin stretching receptor. As soon as you move the, you can say, joint. Let's say this is the elbow. This is elbow. As soon as I'm going to move it, these, you can say, this type side of skin is going to be stretched. Right, this will be contracted. So Ruffini over here will also help me to tell my brain that I'm stretching my hand or I'm contracting or I'm contracting my hand, right? So there are many ones which are going to be helpful in these two, you can say, conditions. And Merkel's, again, Merkel's is going to be for the touch and two-point discrimination, edges, points, not for the, you can say, skin stretch. So skin stretch, it is going to be Ruffini. Option B is going to be skin stretch. Now option C, Ruffini capacity, all right? Sure. Let's move on. Next question. A 40-year-old man was admitted to the emergency department following traumatic injury, diagnosed with the Brown-Sequard syndrome. What is Brown-Sequard syndrome? It's a hemisection of the spinal cord. Half of the spinal cord is cut, right? What is going to happen if the hemisection of the spinal cord is there? There is going to be contralateral loss of anterior and lateral spinothalamic tract. I'm just writing STT over here. Spinothalamic tract. So the person is going to lose the crude touch, right? Then the sexual sensation, then the lateral column, that is pain and temperature mainly. Mainly these will be lost because nobody's going to come to you with the loss of itching and sexual sensation, right? And all other sensations will be lost on the ipsilateral side. So ipsilateral may, you're going to be you will be able to see the loss of dorsal column sensations, all of the sensations, right? And the motor paralysis, the segmental motor paralysis. So loss of proprioception. Proprioception will be gone on the same side. That is true, right? Expected pucha, so this must be the answer. Loss of vibrational sense on the contralateral. No, vibration is also carried by the dorsal column. The proprioception is also carried by the dorsal column, right? So both will be gone on the ipsilateral side. Pain sensation will be lost on the contralateral, not ipsilateral. Loss of fine touch on the ipsilateral. Please remember, only the crude touch will be lost on the contralateral side. The fine touch will be carried by the dorsal column pathway. So it is going to be on the same side. Fine touches will be lost on the same side. So proprioception is going to be the answer over here, right? Option A. Let's move on to the next question. 72-year-old man visit physician, all right, reveals resting tremor, rigidity, right? And the reveals single dose of levodopa. Where do you have dopamine in, deficiency? You have the patients in the Yes, in the patients of, you can say, in the patients of Parkinson's or Parkinsonism, right? So in these patients, you will see resting tremor. Which type of tremors are there? They're going to be low frequency pin rolling tremors, which are going to be there, right? And even you can see bradykinesia, rigidity and tremors. It's a triad to identify that this is a patient of Parkinsonism. And when we give the levodopa, of course, the patients have the deficiency of dopamine. When you give the levodopa, it is going to be, the symptoms are going to actually improve. All right. So the cerebellum, is the problem in the cerebellum? If there is a problem in the cerebellum, there will be lack of coordination, ataxia, dysdiadochokinesia. That means he will not be do alternative movement, right? He will not be able to walk in a straight line. That is the tandem walk. He will not be able to do tandem walk. So all these symptoms will be there. The finger nose test will be abnormal, but nothing has happening like this over here. The substantia nigra, nigrostriatal pathway is going to be the one which is going to be responsible for dopamine action on the basal ganglia. So this is the one which is defective in the patient, and that's why the lesion that they have asked is going to be, must be in the substantia nigra, which is unable to release the appropriate dopamine. The premotor area, it is not the premotor area, and the caudate nucleus. Caudate nucleus, if it is there, he is going to have the whitest dance. It looks as if he's doing involuntary movement, dancing movement. So that is going to be caudate nucleus lesion. But over here, they have clearly mentioned that the patient is going to have rigidity, resting tremor. This will be seen in the Parkinsonism. So answer over here is option B. Let's move on. A motorcyclist suffered head injury, all right, 6 months back. Persistent memory deficits. Choose most appropriately matched option of the memory. So we have seen there are two types of memories, declarative, non-declarative. When you declare a patient, you declare when it is expired. So I told you this is the mnemonic to remember. Declarative memory means explicit memory. Either it is going to be episodic or event based, right? So I have a chart over here which will be giving you the visual inputs also. So declarative means explicit memory, that is going to be either of the facts or the events. If I ask you when your convocation is going to be, so exact date, or when your convocation happened, right? Or when a particular festival happened, right? You might not be able to give me the date right away. Why? Because you may not remember that fact, okay? But if I ask you, how did you feel? What did you wear, right? So you will be able to tell me all those emotions. That is episode. That means events after events. You can tell me that how you got ready. So that is an event. So episode, right? I told you, just remember one episode that there was a new tempo in which one hippopotamus was going on. So if it is an episodic memory, the neo-hippotempo, that means neocortex, hippocampus, and the temporal lobe will be helpful. Remember, whichever type of declarative memory it is going to help me that the portion which is going to help me, that is going to be temporal lobe of the brain, right? And prefrontal cortex, that is also going to help me. Prefrontal helps me in the facts. Remember that. I told you that if it is non-associative, there is no association absolutely. So it is going to be reflex pathway. Happens automatically. Associative learning, which is also known as classical conditioning. So please remember, amygdala and cerebellum. What is the classical conditioning example? Pavlov's doggy, remember? Ivan Pavlov did the conditioning and ringing of the bell. All these particular examples are of associative learning. Timing and perception, that is going to be require a lot of learning and decision making. So new cortex is going to help me out. On the other hand, whenever I have learned any skill, so in that skills are usually motor, they're not sensory. So that is going to be done by the cerebellum, motor cortex, and to that, the striatum is also going to help me out because the movement is going to be done via the, or you can say the planning is done via how to do the movement, that will be done by the basal ganglia.